Hi, everyone, and welcome to today's roundtable session, Create Capacity, Restore Margins, and Reduce Burnout with Real-Time Operations. This is Mackenzie Dean, Managing Editor with Becker's Hospital Review. We'll begin today's session with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the session by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's session to access the recording. At this time, I am so pleased to introduce our speakers. First, we have James Hereford, who is the President and CEO of mHealth Fairview. James joined Fairview in 2016, bringing extensive experience with strategically guiding organizations, strengthening core operations, and bringing teams together to drive cultural change. Prior to joining Fairview, James served as the Chief Operations Officer at Stanford Healthcare and the Palo Alto Medical Foundation, among other roles. Next, we have Shelley Shore, who is the Chief Financial Officer for Common Spirit Health, Northern California Division. Shelley currently oversees financial operations of the division, which encompasses $2 billion in net revenue, and advises the service area's Senior Vice President of Operations regarding the development and growth of the network's hospitals, ambulatory care sites, physician alignment, joint ventures, and payer relations. Before joining Common Spirit Health, Shelley spent 12 years at Mercy, where she served as a regional CFO for Southwest Missouri, Kansas. And last but not least, we have Michael Muka, who is the Vice President of Customer Operations at Qventus. He has over 20 years of experience in technology operations and consulting. Prior to joining Qventus in 2016, Michael served in executive roles in sales, marketing, and customer success at Evolent Health, MD Byline, the Advisory Board Company, and other software-enabled service providers. As you'll see on our next slide, we have a really exciting agenda lined up for you all today. We'll start with a few brief presentations to provide additional context. First, we'll hear from Michael, who will give a quick introduction to Qventus. Then James will give a short presentation on a case study from mHealth Fairview. And then Shelley will provide additional context on Common Spirit. We'll then segue to the bulk of the discussion, which is the panel Q&A. In this portion, the three panelists will engage in a fireside chat and explore the key themes for this session, including how they're creating capacity, restoring margins, and reducing burnout through real-time operations. So without further ado, it's my pleasure to turn the floor over to Michael to kick things off.
Great. Thank you so much, Mackenzie, and thank you for everyone for giving us some of your time today. Really excited to share this next hour or so with you. So let's start with the topic that brings us here, hospital operations. Needless to say, it's a big industry challenge. We have world-class clinicians, world-class medicine, equipment, and therapies. We're being held back from achieving our potential, both clinically and financially, by poor operational systems and processes. We don't have access to the data we need in the moment to make the right decisions every time on our front lines and in the folks that support them. Our processes tend to be highly variable, both inside and across our facilities. And because of all this, we rely on our frontline teams to go above and beyond, to make diving catches, to bridge the gaps. And frankly, it's not working. It's expensive, it results in suboptimal care, and it's taking a huge toll on our frontline teams. Those are the challenges that our founder, Mudit Garg, experienced while working with the different health systems during his time at McKinsey. His vision for Qventus then and remains the same today, and that's to partner with health systems for real-time operations using innovative technologies and deep expertise to unlock world-class healthcare. A quick overview of Qventus for anyone who may not be familiar. We provide the first real-time operations system for healthcare. We apply modern innovations in artificial intelligence and machine learning, behavioral science, and operations management, and combine them to optimize hospital operations. We do that through a comprehensive system that includes an underlying platform for real-time operations, best practice solutions for operational challenges across the acute setting, from inpatient, emergency department, peri-op, and command center capabilities to manage processes that are best operated centrally, and then change management services to ensure we take an inside-out approach to deliver the solutions and hardwire continuous improvement. We're a proven partner with over 120 deployments, successfully improving operational outcomes in community hospitals, academic medical centers, and large health systems. So how do we do this? Why do we do this? According to the advisory board, 22% of hospital days are excess days. When you think about it, it's a pretty staggering figure. It's the equivalent to a single excess day per patient. When we extrapolate that across the industry, it translates into $9 billion wasted annually. Or said another way, for each of the individual health systems that we work with, it's millions of dollars of waste per facility, or tens of millions of dollars per health system, each and every year. As we work closely with our partners over the years, we've spent a lot of time researching how to simplify what it takes to consistently and sustainably reduce length of stay. And here's what we know. When you dig into the data, the key to excess day reductions is pretty clear. Patients that have a discharge plan identified early, as best represented by having an estimated discharge date and a disposition captured before the second midnight of their stay, see 91% fewer excess days. On the left, you can see that the average excess days per patient across the study group is 0.44. But again, you can see how stark the difference is between the patients that don't have EDDs and dispositions identified early and those who do. It's a 0.7 day difference. So it seems pretty simple, right? But we all know nothing in healthcare is this straightforward. We wanted to understand whether this holds true for all patients. The first objection we always hear is, sure, that makes sense for most patients, but not for our most complex patients. So we looked into the data to see if that held true. Are there cases where clinical complexity prevents early discharge planning? We looked at the difference across the most common DRGs and found the pattern holds. Early discharge planning makes a difference for complex patients with high GMLOS on the left, as well as for our less complex patients with lower GMLOS, like joint replacements, on the right. The next thing we explored is how excess days vary across different discharge dispositions. You can see that in this chart, which breaks out the same data we've been looking at into least complex, those who are going home with self-care on the left, to the more complex, those going home but require services in the middle, and those going to skilled nursing facilities on the right-hand side. Here you can see a couple of things. First off, the relationship still holds. Early discharge planning is associated with fewer excess days across different discharge complexities. However, early discharge planning alone isn't enough. For complex discharges to home health or SNFs, even with early discharge planning, we still see up to 2.5 excess days per patient. Now, we also found that discharges requiring post-acute placement and services result in the majority of excess days. No surprise to anyone who pays attention to this. SNF, for example, is a classic Pareto. 21% of the encounters we studied resulted in 81% of the excess days. So clearly, for higher complexity discharges, we need to do more than early discharge planning. And when we look at the data, we found that identifying barriers to discharge is really important. Things like pre-authorization on day 2, family engagement, et cetera. When barriers for SNF discharges are identified before the second midnight, we see 39% fewer excess days in those patient groups. So the data around these best practices are really clear. If you can do discharge planning and identify barriers to discharge before the second midnight, you can significantly reduce excess days for all types of patients. So what's holding us back? From our perspective, and as we talk to our partners, it really can be boiled down to 3 main things. First, our core technologies don't reinforce these best practices. They just weren't designed with these processes in mind. In particular, our clinical documentation systems, our EMRs, don't really help a lot here. Now, when we talk to hospital executives, we'll sometimes hear them say things like, well, if my EMR can do 70 to 80% of what's needed, we're good. Or, I'll wait a couple of years to see if our EMR can provide me more in this area. Now, if you come from outside of industry, as I do, and you think about it, I don't know of any other industry with our challenges, low margins, threatened business models, people-heavy system dependencies, who think that they can continue to think this way and get a different outcome. What those folks would tell you is that the last 20 to 30% is the most important. Second, our care progression models simply aren't discharge focused. We're generally not embracing these best practice standards and applying and reinforcing them consistently. Finally, there's really no support for continuous improvement. We have so much data and we spend tons of time talking about what to do, but we don't have a simple standardized approach through tools, processes, or people to manage what matters and drive continuous improvement, whether it's across the house or across the system. Now, these challenges with discharge planning are consistent with what we've seen in hospital operations more broadly. And over the years, working closely with our health system partners, we've developed a complete system to address these challenges. As a quick introduction to the Inpatient Solution approach, there are three main elements. First is a real-time platform. This integrates with your EHR and uses artificial intelligence and machine learning, behavioral science, and analytics to create a closed-loop system for managing operations. It allows you to identify operational issues like bottlenecks in patient flow before they occur, orchestrate actions among frontline teams and ancillaries, and manage accountability so you can assure that you're effective. The platform is the core of the system. Now, on top of the platform, we've developed solutions for key operational challenges. These are best practice combinations of software, models, operational processes, and management practices. We've developed these in conjunction with our partners and industry thought leaders. We have solutions for the inpatient side of the world, the emergency department, perioperative, and command center or system operations. These solutions are how we address that thing I mentioned earlier, that issue of care progression isn't discharge focused. For example, we have a module within our inpatient solution that's specifically focused on automating and simplifying discharge planning best practices for every patient. And then finally, we have a team that works with you to drive change management and operationalize the software, because we realize this is essential for success. Nothing gets done in healthcare or any other place with operational processes these complex without bringing our people along and having deep involvement from them to help us solve these problems. It's not enough to provide that great technology. It's just as important to ensure that the technology is embedded into the culture and adopted. Our team includes clinicians, project managers, process improvement experts, and technical specialists who use a proven methodology and deliver consistent results. And this team works hand in hand with you over time to ensure success as well. And finally, and most importantly, we're helping our partners achieve really transformative results. We've talked about the how, but at the end of the day, as we all know, this is the why. We're incredibly humbled and proud to see that in 2019, we were able to reduce over 50 years of excess patient days collectively across our patient cohort, our partner cohort. We're incredibly excited about the impact that we're going to have in 2020, even acknowledging the just incredible challenges that health systems across our nation and across the world have been experiencing in light of the pandemic. And what this allows us to do is to help our partners decrease their length of stay by anywhere from 0.3 days to 0.8 days. And importantly, that drives a 50 to 90% basis point increase in cash flow, all of which results in millions of dollars of annual financial value per facility. But it's not just metrics. We also help our partners drive systemness, increase the value of their EHR without a high burden on their IT teams, and improve quality and the patient experience. And lastly, we enhance the lives of frontline teams. Really, this is what we're all about, simplifying healthcare, and the simplification of healthcare needs to start with the folks who are so overburdened on the front lines. As you can see from this last quote, we're making great progress here and experiencing great feedback from our customers. And so with that as a brief background of Conventus, it's now my pleasure to turn things over to the CEO of mHealth Fairview, James Hereford. James, thank you so much, sir.
No, it's my pleasure. Thanks for asking me to be a part of this. So great setup. Let me tell you a little bit about mHealth Fairview. If we could go to the next slide. So we're based in Minnesota. We have a significant presence in the Twin Cities, but we have hospitals throughout much of Minnesota. We have 11 hospitals, 2,400 or so beds, including an academic medical center at the University of Minnesota. About $6 billion plus in total revenue. We have a network, including a clinically integrated network of community providers of about 5,000. Approximately 34,000 employees, 105,000 inpatient admits per year. And I love that my team put that we have 2 instances of Epic here. I think they do that to try to trigger me because I have gained some notoriety about my feelings about Epic, but because of a merger with the organization, we have now 2 instances of Epic, and we're integrating those this year. So a little bit about us. Next slide, please. So here's the challenge, and I'm reminded of the Winston Churchill quote about Americans can be dependent on doing the right thing as soon as they've exhausted all the other possibilities, and I would think it applies to healthcare and healthcare organizations as well. The situation that we find ourselves in, or I found the organization as I came to Fairview was. It's a system that really has almost all of the components across the continuum of care that you would love to have. However, it had really been driven from a almost holding company mentality. Just put the pieces together. Every hospital ran independently of everyone else. The ambulatory system ran independently. The health plan ran independently, et cetera, et cetera. And part of my goal was to really drive a level of systemness so that we could leverage the capabilities and the capacity we had more fully. So, excuse me, I had been involved with Cuventus and Mudet from really the outset when I was at Stanford and they were at the Stanford incubator. And we talked a lot about what I viewed as some of the challenges, and Michael did a nice job of elucidating those challenges in healthcare. For us, it was about creating capacity and throughput. We tend to depend on our individuals and put a lot of pressure on them in terms of staff, nurses, physicians, other clinical members of the team. But the result is a pretty disjointed process. It's not just the output is discharge issues, but the process itself is very unsystematic in terms of moving people through the progression of care. We wanted to make sure that we were leveraging our capacity, meaning, that we had the capacity to keep and really have patients in our system. We are pretty significantly, we're a big organization, and we want to make sure that we're leveraging those very expensive capital assets. Additionally, we wanted to support our staff because, I think we have heroes, and we've certainly demonstrated that over the last year through this pandemic, but that's always been the case. The problem is because we have so many capable, bright, smart, unbelievably mission-oriented people, our systems have really depended on them, and we've placed undue burden on them to do everything. And the technology hasn't really supported them. And finally, to be able to continue to reduce unnecessary variation in the system. Obviously, there is variation that's necessary. We treat individual patients individually, but to be able to understand and to have constancy and low variation where we can makes us more reliable, more capable, more efficient, more effective. All of that's necessary to achieve the level of systemness that we're after. Next slide, please. So the challenge was, how do we establish this? Do you start in one hospital, one component of a hospital, et cetera? So what we did was establish a system operations center as kind of our hub, our glue, if you will, in which we could create visibility across the system. And I'll give you a quick anecdote about why I thought this was crucial. I was going to Gemba. As a good lean practitioner. I happened to be at our academic medical center in the cardiac ICU. And it was, as some of you probably have experienced, one of those days where it was, everybody is, cranking. They're on, edge because they're, at the edge of their capacity. They're scurrying to try to figure out who can be discharged, downgraded, and moved. But they just didn't have capacity. And being, the master of the obvious, I asked the charge nurse, well, have you called Southdale or anybody else? And her answer was, Southdale's another one of our hospitals. Her answer was, yeah, we have, but nobody has capacity. So later that day, I happened to be at the ICU at Southdale, asked the nurse there, So, how's it going? And I could observe, there wasn't many people in beds. We were, probably at 50% capacity. So, well, it's been a slow day. We didn't have a lot of work coming out of the ED overnight, and the OR, we didn't have high volume. So we sent staff home. Well, what a great example of managing the micro without having any sense of the macro. So she was doing the right thing from the information that she had, was to try to conserve resources, make sure that we're matching the people capacity to the demand that she could see. She had no idea what was going on at the other hospitals. And so our idea was to be able to create this system operations center to give us that level of visibility. Next slide, please. So we did that. We did that about a year and a half ago, almost 2 years ago now, to be able to give us situational awareness, to be able to create visibility across the system, and to support capacity collaboration so that we could make sure that we were load leveling, leveraging our overall capacity, making sure that we're fully leveraging it. It also allowed, because of Qventus capabilities, the ability to anticipate, right? So because of the analytic capabilities, we could anticipate when the data was indicative that we were going to see crowding up to 3 to 4 hours ahead of time in an ED, which was incredibly helpful for us to be able to get in front of problems. Because one of the things that we're really good at healthcare is fighting the fire that's in front of us. We're not so good at anticipating what fires are going to start and not allowing them to. And so this gave us a different level of capability. And so with that in hand, we were able to have really system-wide management of our overall bed capacity and how we were load leveling and managing that capacity much more effectively. So that also allowed us to be able to use some of the predictive and suggestive tools, the AI, to be able to help support the people both in the hospitals and in the operations center to suggest when an action might be prudent. Next slide, please. This became really important as we are experiencing and have experienced a pretty significant global pandemic. And what we were able to do with that capability is turn that into a view. Our critical care command center was really a statewide resource where we partnered with the Department of Health to be able to manage ICU beds across the state as we saw significant surges, both in the end of May, early June, and then the second surge in November and through most of December. It allowed us the ability to make sure that we could get patients into the level of care that they needed across the state and have visibility about that. So it helped both the state and the Department of Health have confidence that the healthcare system was able to manage bed placement and patient placement and work together in a collaborative way. And I'm very proud of what we were able to do. And Minnesota tends to be a fairly collaborative place anyway, but the technology and the ability to have this view into what was going on, allowed technology support to that kind of natural collaborative instinct that we tend to find in Minnesota. Next slide, please. So, and again, it allows us to have the kind of visibility, real-time situational awareness. It also allowed us, and we leaned on Qventus quite a lot in terms of predictive models around what we were expecting to see over some future periods of time, which again, to the degree that you can anticipate and have some sense of what's going to happen, it allows us as a healthcare organization to be much more agile, much more capable of adapting to those circumstances instead of waiting until we're in the middle of the fight and then trying to figure out how we were going to respond. Next slide, please. So the results have been very encouraging. We see a pretty significant, up to 1 full day lowering of our variance day rate where we've deployed the solutions. One of the things that we employed at Stanford was this idea of how do we get things moving quicker in the day? How do we get our discharge orders in? How do we get more patients discharged earlier than simply waiting towards the end of the day. And so we saw significant increases both in the orders placed, but also the discharges before 11 a.m. And our ability to be able to proactively identify ICU patients that were ready for step down. Now, obviously, this is not a replacement for clinical judgment. That is never the intent. But to be able to suggest, because an individual clinician, a nurse, an ICU physician, a critical care physician, can't be expected to monitor every patient continually in real time, 7/24. That isn't going to work. Technology has to support that, but it can't replace the clinical judgment once alerted about whether that patient needs to be stepped down. Well, this clearly demonstrates that that's working. And it's taking a number of the tasks off of the load off the shoulders of the patient, of our staff. One of the things I'm most proud about was the quote that's at the bottom. I happened to be, at a ED in our Ridges Hospital, and a nurse came up to me and said, finally, you guys deployed a technology that makes my job easier instead of harder. And I just love that quote, because I think it does go to so much of the technology that we've employed doesn't make things easier. And I think healthcare has been unique in that way. Next slide. And I think that's the end of my presentation. Yeah. So I think we're going to do Q&A at the end, and I will turn it back to Michael.
Great. Thank you so much, James. Really appreciate you taking us through that. Shelley, you want to hand it over to you? Shelley, I think, unfortunately, we're having a little bit of technical challenges and isn't able to be on camera as we go forward. But thanks so much for muscling through, Shelley.
You're welcome. Thank you. Thank you, James and Michael. So before we dive in, I want to talk a little bit about Common Spirit Health for anybody who might not be familiar with us. We are a merger of Dignity Health and Catholic Health Initiatives. In 2019, we formed an alliance. We are the second largest not-for-profit health system in the country, with 137 hospitals, 1,000 care centers serving 21 sites, over 150,000 coworkers. The Northern California division takes the northern half of the state of California, and we have 13 hospitals, over 16,000 coworkers and providers in our division, and about $5 billion in net revenue. And our EHR is Cerner. Next slide. In 2018, our leadership team at what was then Dignity made operational efficiency using automation and AI as a core pillar of our strategy. The COO of Dignity Health System and now the president under Lloyd Dean, Marvin O'Quinn, laid out a vision to use automation to help our frontline teams. We knew we needed a partner for this type of transformation. We brought in Qventus as a core part of this strategy. This strategy is more important than ever as we continue to consolidate and integrate across the country both Dignity Health and Catholic Healthcare Initiatives as one organization, Common Spirit. If we double-click into the strategy, we're also going to recognize significant value creation opportunities. So first of all, we need to reduce excess days. And we had significant financial opportunities in reducing excess days in the tune of $15 million just in the Northern California region alone annually. In the context of the broader economic pressures we face today, that's significant from a headcount perspective. Second, we also needed to make work easier for our frontline teams, specifically the nurses. Third, we needed visibility into operations. As a leadership, we often hear anecdotes about what's driving length of stay, delays in transfers, et cetera. So when you actually have the data that is the root cause of problems, you can then take targeted action. One of the things that we would hear continuously is that the problem with length of stay and discharging patients had to do with post-acute transfer beds availability in a rehab or a SNF or a skilled unit. And often that is the case, but depending on, and definitely right now we're seeing that after the pandemic, COVID patients are hard to place in a post-acute facility. However, we did find a lot of times pre-pandemic that anecdotally that's what everyone thought, but it might only be 35% of our problem. And we actually had other problems to discharging that weren't obvious in the moment of the day without taking an objective approach outside of the process of the whirlwind of what was going on. Sometimes it was prioritization of lab results or
a consult physician couldn't make it in time to ease the discharge planning. So having this real-time data absolutely helps your flow. And then last but not least, we needed to drive systemness, just as James said. Just in our Northern California region, we needed to drive more systemness. And if you take the bigger prospect of COP and Spirit Health, we have 130 hospitals, so the opportunity to drive systemness is significant. Next slide, please. Here's a discharge planning example, and I want to highlight some of the inpatient solutions that we've rolled out, which may look familiar to you since Michael mentioned some of them earlier. Across the sites, we've rolled out discharge planning, which is the first box, and it hardwires discharge planning best practices for our frontline care teams and uses AI and machine learning predictions to help us plan. The second box you see is barrier management, which also uses machine learning to help proactively identify barriers for complex discharges and orchestrates coordination with ancillaries to resolve those barriers. And then last, we have performance improvement automation, which gives our leadership team visibility in how the teams are doing compared to best practices so that our managers know where to focus their improvement efforts, offer kudos to the team, or dive in real time and make changes that can affect the flow during the process. Next slide, please. Now I'm going to share some of the impacts we've seen at our Mercy San Juan Medical Center, where Qventus Inpatient Solution has lived the longest. This is a facility in my division. Using the Qventus best practices, we focus on two of the most statistically significant drivers to reducing our excess days. The graph on the left shows the difference in our excess days for patients without discharge planning before their second midnight, 3.77 days, compared to 1.63 days when the care teams do discharge planning and set the estimated day of discharge and disposition before that time. That alone is necessary, but it's not sufficient to reduce the excess days. You also need to identify and resolve discharge barriers early. So the graph on the right shows that the excess days impact of identifying barriers after or before the second midnight of a patient's stay, and you'll see that that's more significant. This is excess days. I'm sure everybody's aware, but not only is this costly for our teams, but it's also not good quality for the patient to be longer than they need to be. So yeah, next slide, thanks. And then last of all, I wanted to highlight some of what our teams are saying. You know, I can read those for you. Qventus is an amazing tool. We can't go wrong. It's added efficiencies. Our discharge meeting is Qventus, the best I've ever attended. Our units are competing to be the top performer. Engagement rounds have never been better. At the end of the day, we just want to make their jobs easier. We want to do the right thing for the patient. Patient flow is so important for the patient, for quality care, and for our team. And to be able to give them a tool that takes the guesswork out of the real-time moment is critical to managing care. Thank you.
Shelley, thank you so much for that. And so now we'll turn to our panel, to the Fireshot Chat with James and Shelley. And so for the folks who are participating on the presentation, please feel free to chat in questions at any time. We'll try to answer as many of them as we can before we break. And if there are any that we're not able to get to, we'll make sure that we follow up and provide those answers to you. So maybe we'll start with asking each of you to elaborate on how real-time operations have supported your strategic priorities. I know you both touched on this in your presentations. So I guess maybe the first question, if we can start with you, Shelley, and then we'll go to James, is why did you decide to partner with Qventus?
Yeah, thanks. You know, one of the most challenging issues in hospital operations is managing patient flow appropriately. I just alluded to that. We want to ensure that we're giving the patients proper treatment and managing care at the appropriate time, not keeping the patient too long or too little. We're having the right consultations, the right treatments at the right time. Qventus helps us manage that flow by pointing out the barriers of care to flow, as I stated earlier, allows for real-time intervention, and it also allows just open space to see what is causing the problems in our patient care flow. And it's not easy always to see in the whirlwind, but it's a great tool to be objective and accurate and to do real-time intervention.
Great. James?
Well, one of the foundational things for us is being able to provide the highest level of quality and safety. And you cannot do that unless you have operational reliability. And partnering with Cuventus, as I said, I've known Cuventus for a long time, a great respect. And not only do I respect the technology, but I really respect the partnership approach that Cuventus takes in terms of being able to come in, not simply say, here's our cookie cutter approach, but understand the context and understand, the delicacy and the challenges of, how do you get a technology implemented in a way that really changes practice and changes processes over time. So, they just were the natural fit for us because of my prior history with them and because of the approach.
Great. And James, you mentioned more traditional approaches to solving flow. And for those who aren't familiar, I'm sure many are, your infamous letter to Marshall on Madison. How did you think about what lives and should live in the EMR and where you do need new capabilities, how to think about reconciling that with the EHR investments you have?
Well, so I'm going to try not to go down the rabbit hole of my opinions about the EMR, and Epic specifically is the one that we use. But the EMR is essentially a transactional and a documentation tool, right? So it allows us to document, it allows us to transact in terms of putting orders in or dropping claims or what have you. It isn't a terribly good tool in terms of allowing us to be proactive, predictive, to be able to bring the right information to somebody that's task or process specific. It's challenging in that way. It's not built for that. The architecture doesn't support it very well, where Cuventus does. And so, a lot of my desire and my wish is that Epic continues to make it easier to integrate tools like Cuventus, because I don't think that's a threat to Epic. And I think it makes us all better where we can leverage the information that is part of the EHR, but not be solely captive by it.
Great. Thank you, James. And Shelley, you described the significant financial opportunity that was in front of the Dignity system and the Common Spirit system now going forward, as well as the region that you're responsible for. I'd be curious, as to CFO, how are you thinking about that today, both in terms of the traditional import of excess day reduction and how that has changed, either higher or lower, in the things that you care about in light of the last year that we've all experienced in healthcare?
Yeah, I mentioned earlier that excess days can be as much as $15 million annually. And reducing costs in healthcare is directly related to managing our labor, our supplies, and the length of stay. We want the patient to have the appropriate care at the appropriate time. And this has been very fluid. Specifically with the pandemic, we've seen patients with sicknesses and illnesses that we haven't seen before and trying to manage that. So the data has been extremely helpful in managing our length of stay and our discharge planning with these patients. Like I said, we want the patient to receive the appropriate care at the appropriate time. There's specific knowledge that says when a patient gets the medications and the labs and the things that they need at a certain time throughout their stay, depending on their diagnosis, it drastically improves their outcomes and quality outcomes when they're discharged. We also know that having a patient not have the right care or the right time or the right discharge impacts patient satisfaction. So not only do we want good quality outcomes and the best care for our patients, but we want the ability to place patients where they need to be, discharge when they need to be, get the care that they need to be. And all of this impacts not only our satisfaction for our coworkers and our patients, but our margins and our quality outcomes. We don't want the patients in the hospital too short either. That results in readmissions. So all of these are significant financial impacts that can be managed with AI.
Great. Thank you, Shelley. Now, let's turn to COVID. James, you talked a good bit as we were setting up your experience at mHealth Fairview about how you worked with Cuventus and across your broader systems operations infrastructure to respond to COVID. Can you share a little bit of how that experience was different in light of having access to the technologies that you did as opposed to if you hadn't?
Well, I think it was different in terms of we were very adaptive, right? So we were adaptive from a people side, as almost all healthcare organizations were, in terms of using command centers and our emergency response processes. But the challenge in those events is the flow of information. And especially when we go into this, it's one thing. I was at Stanford when the plane crashed at SFO. That whole emergency lasted 24 hours. This one, we're still in, right? And it has been ongoing. And especially at the outset, we didn't know what exactly we were dealing with. We had limited information coming out of Wuhan, China, and from Lombard, Italy, and from New York, and from Seattle. But what we didn't know far outstripped what we did. And so that flow of information made that command center structure work. And it allowed us to have, a view of the current situation in a way that made us much more effective in terms of how we responded. And allowed us, I think, to be able to have, some of the best outcomes in the country in terms of being able to manage COVID patients successfully.
Great. And Shelley, I know you touched on this a little bit, but as you all look at Common Spirit, at recovery, whenever we get to that point where we can start thinking more tactically and pragmatically about the recovering our operations, how do you think about what's important and how critical real-time operations are going to be for Common Spirit as you go forward to put yourselves in the best position to succeed post-pandemic?
We absolutely can tell in real time the impacts to our patient flow. I stated earlier that this assists us in driving systemness. It eases the burdens on our staff. It gives us visibility into operations and reduce waste. In healthcare, most of your costs are in the real time. They're in your labor and your supplies. That's all of your controllable costs, really. And so managing those not only improves quality, but it helps us reduce our waste and give us a better margin. It sets us up for excellence as we're seeing more and more change and disruption in our industry more than ever before. More entrance into the market. We have changes from inpatient to outpatient. There's statistics that say that we might see as much as 40% of our inpatient DRGs go to outpatient in the next 10 years. This takes speculation out of the flow and lets us focus and be prepared for real-time changes as we need. And it gives us data so we can see how care is managed. And if we have to make a change, we have some good data to help us make the right decisions going forward and make appropriate changes without any guesswork, which is really most clinicians don't want guesswork anyway because that directly affects patient care. So I'd say it's very important for our success going forward, and specifically in the changing times that we're in today.
Great. James, I've had the great fortune personally of working very closely with the mHealth team for the past 3 years, and I know how core people centrism is to the way that you think about all the work that you're guiding and leading. You mentioned the quote of the nurse that you spoke to, and essentially this being the first time that there was a solution given that was helpful versus for them versus to them is a way that I've heard it characterized. Can you spend just a minute or two talking more broadly about how important reducing the burden on frontline teams is, and how do you guys think about it there at mHealth?
Well, I think it's crucial. I think that one of the secondary impacts of COVID that we're going to be dealing with for a long time is burnout of our staff. The problem is that we kind of went into this with a burnout issue in healthcare, and then we've experienced a pandemic. And a big part of this has to be, how do we make their jobs simpler? How do we make it easier to have the information they need to apply their professional expertise? There is a process component of this, of course. We want to have a known way of doing things because that baseline allows us to improve. But so much of this is we've got a human glue system. I don't think any role in our healthcare system better depicts this than social work, who basically are human glue in a bad system to try to figure out how to get somebody discharged or placed or supported. I am in awe of these people. But at the same time, we shouldn't have to depend on heroics in our people to get the job done, to help support our patients. That's not a reliable system. It doesn't create great levels of patient safety and quality. It doesn't create the kind of experience that we want our patients to have. So, I think technology has to play a big role in that. I like the way that Qventus has helped. I think we've got still a long ways to go to be able to get to a place where people can concentrate on those things where they uniquely have to add value, where they can leverage their expertise, and a lot of other things are made easier for them. But I think we've made good strides in terms of, at least in some of our operational areas, through the application of this tool.
Great. And you guys have both touched on this a little bit, but tackling these kinds of challenges where the level of operational change is so high, and being asked for a group of people who feel like their cheese is being moved pretty regularly. So how would you describe the nature of your health system's relationship with Qventus? Do you think of it as a strategic partnership, and how has it felt in terms of working together to make sure that we're working not just on the hard things that are required around the outcomes, but the soft things that the outcomes are dependent upon to ensure our people are included in these processes? James, maybe you want to start?
Sure. Well, I think it's whether something is strategic or not is, I guess, evaluated post hoc by the impact it has on the market. But the other word that you used is partner, and I think that is the right signpost here. I've felt like we've had a good partnership where we have collectively come together and learned together around what we bring to the table, what we need to bring to the table, how we interact together. And I'm not sure there's much more than you can ask for from a partner than that sense of, that combination of we bring known skills and expertise, but also that humbleness and openness to learn, to say, but we don't know everything. And we have to continue our own learning path, and we have to learn your context, and we want to learn with you. To me, that's the part that I think I feel the best about in terms of how our collective team, individual Fairview and Qventus people have come together. And you look at the progress that's been made over the couple of years of this work, not only in terms of the outcomes, but how well we work together, how quickly we're able to adapt and leverage each other. I think that's the signal of a great partnership.
Great, thank you. Sorry, my phone is ringing. Let me get rid of that. Apologies for that noise there. Shelley, any thoughts you have on that same question?
I'll just reiterate what James said. It's the dual learning. I mean, I've worked many times with the Qventus team. They've asked me a lot of questions about patient flow. They've given me some great insight and helped me many times. And it is a partnership. We interact and collaborate. And I don't think I can say it better than James said. It's a mutual learning and humbleness. And it's really nice when you have a partner and you're trying to figure things out together. And I think that's where you come up with the best success. And Qventus actually is a really talented team. I enjoy working with them and the thought processes that go into improving products every single day. And it's fun for me to get to interact. And so I think it's an amazing partnership.
Great. Well, thank you both. And I know that we were hoping to wrap up by 45 minutes after the hour. So I think we'll do one final quick closing comment, and then wrap up, and we'll close the loop with folks who have had a bunch of the questions that are being fired in offline. So Shelley, you want to kick us off? Any parting thoughts you want to provide?
Yeah, I just want to say that it's definitely worth the time to implement and train and the investment for a product like this. It gives you a leg up on your operation, and it helps the solution. It helps key leaders focus on their challenges and strategy and care, and let the tool help with the barriers to care. And that can take an inordinate amount of time for leadership. To have that done for you is definitely worth the investment, and you get a substantial return in care and staffing and leadership satisfaction.
Great. James?
Well, I think we're at a point of crisis in our healthcare system. We have balanced the books over the last 15 to 20 years on the backs of individuals to absorb our medical inflation through deductibles and co-insurance and other premium shares. Our consumer friendliness is low. Our waste is high. Our quality and our safety is mediocre. I think that we have to, as an industry, reform ourselves. And if we don't pay attention to the kinds of things that, a tool like Cuventus helps us do better, I am concerned about the where our industry goes. We have to be better. And I think the kind of things we're doing with Cuventus are absolutely crucial to making healthcare more affordable, easier to use, easier to understand, and ultimately more effective.
Well, Shelley, James, let me just thank you guys again for your time, your thoughtfulness, and for sharing your experience with the participants. Mackenzie, we'll hand it off to you to take us home.
Wonderful. Well, I just want to say again to James, Shelley, and Michael, thank you all so much for your insightful, informative remarks today. We so appreciate it. And thank you also to Cuventus for sponsoring today's session. Like Michael said, the Cuventus team will follow up offline with any questions that have come through. Otherwise, I hope everyone enjoys the rest of your day, and we look forward to having you join us for future events.
Thank y'all.